Dr. Starziak here again. In this video, I'm going to demonstrate different hand holds for using balanced ligamentous tension technique in the lower extremity. Generally, when I'm treating the lower extremity, I'm going to start at the ankle. But if there is a compelling reason for me to start anywhere else, I will do that. So if the ankle's not involved and the knee is very much involved, I might start at the knee. Or if it's an SI thing where it's more of an effect that happened higher up is creating an issue lower down, then I might start with like a femur SI hold. But otherwise, I usually start in the foot, move up through to ankle, and so on, knee and then SI joint. This first hold, I take, if I'm on the patient's right side, I'll take my left hand and place it underneath the calcaneus in such a way to contour it, to not try to be invasive or intrusive, but just to follow the natural shape of the region so that I can blend with the tissues that I'm palpating. And then I'll take my right hand and I will wrap my fingers over the top of the foot and have the thumb on the bottom near the ball of the foot. This is a very good contact to assess the general balance of tension in the whole foot. It's not really great to treat any one joint very specifically, but it is good to get a feel for the whole foot and get more information. So if one part of the foot is very stuck, when we're finding balance with this hold, it will tend to draw our attention to that stuck part. One of the troublemaker regions is the junction between the calcaneus and the cuboid. That very commonly can lead to pain in the ipsilateral SI joint. Then also the talus on the calcaneus. That is a particularly troublesome spot in ankle sprains and it's very important to address. Dr. Kuchera, the junior, he did some research with the military showing that that's the most important joint to address after ankle sprains to speed recovery. So here I can very easily check for ease and supination being a combination of inversion, internal rotation, and plantar flexion. Pronation being a combination of eversion, external rotation, and dorsiflexion. I can also compress through the metatarsals with my right hand so that as I find balance through the calcaneus, and that's going to also, that lower hand that's contacting the calcaneus can also find balance with the talus and the ankle mortise, and then I can find balance in the forefoot and midfoot using my right hand, where generally the forefoot will move down on the medial aspect, so on the big toe side, and up on the pinky side, or vice versa. It's a sort of twisting effect usually. And frequently it's doing the opposite of what the calcaneus is doing. So if the calcaneus is going into supination, well then generally the medial aspect of the forefoot will be moving down and the lateral aspect will be moving up. And that will typically also play out at the calcaneus cuboid junction, where the cuboid, if we're looking head on at the right cuboid relative to the calcaneus, the cuboid will be rotating clockwise relative to the calcaneus. And that's problematic for the arch because the cuboid is the cornerstone of the arch, because the navicular and the cuneiforms sit on top of it. It looks very much like one of those old stone bridges where the bottom of the stone is thinner than the top and they're wedged together and they create this arch. That's the same thing if you're looking straight on at the foot at how the cuboid relates to the navicular and the cuneiforms. There we go. And same thing, we don't want to rush it. It'll just gradually, it will release itself if we follow balanced tension. So that's a great hold for the whole foot. Now if I wanted to focus more on the talocalcaneal junction, I like to do it like this, where I'll keep the left hand where it is, take the right hand, move it around just beneath the medial and lateral malleoli. I'll contact with my index finger and my thumb so that I can hold the talus still while I rotate the calcaneus medially and laterally, and also create a little bit of plantar flexion when I rotate medially, dorsiflexion when I rotate laterally, inversion when I rotate medially, eversion when I rotate laterally. And it's pretty easy to feel which direction is easier. And in her case, it is a medial rotation. So if I'm looking at the calcaneus from the bottom, it would be clockwise. And then I am stabilizing at the talus so that there's that a sort of twist with the calcaneus, twisting clockwise on the talus, and that engages the ligamentous balance really well, and there it releases. All right, this next one, the calcaneus and cuboid junction, I'll take my right hand under the heel, then my left hand, with my web space, I'll find the styloid process of the fifth metatarsal. So you can see it here on her left foot, the styloid process of the fifth metatarsal, and then I'll place the web space of my hand right there so I'm over the cuboid. By now, if you're an osteopath, you should have a good knowledge of the anatomy. So I'll hold the calcaneus still, or first actually allow the calcaneus to go into its ease, and then hold it still, stabilize it, while I then gently check what the cuboid wants to do. And in her case, the cuboid, the lateral margin of it wants to move superior, while the medial margin wants to move inferior. So that's like if I'm looking head on at the cuboid, it is rotating clockwise. If I'm looking from where I am down at its anterior surface, relative to the calcaneus, it's rotating clockwise. There, then it releases. So if there is still an issue in the talus joint after what we've done, well, we can work with that as well, and that's mostly going to be plantar flexion and dorsiflexion. I find that I pretty much never have to individually address the talus and the mortise. By the time I've done what I've just shown you, if there's things to treat, and then I do this next hold, it's never an issue, because in pretty much each one of them, I'm addressing the calcaneus, and when I take the calcaneus into plantar flexion, well, really that motion is occurring at the talus. So it automatically, when I'm feeling the balance of tension back here in the Achilles and the medial lateral ankle ligaments, well, it's balancing the tension of the ligaments that are holding the talus in place. So now you can't see this on the other side. I'll switch the legs so you can see it better here. When I go to treat the tib fib and the interosseous membrane, this hand I have my MCP behind the proximal fibular head, and then my thumb in front of it. And then I have my hand under the calcaneus with my pointer and middle finger behind the lateral malleolus. So then I can very easily assess this internal rotation and external rotation. Now most people prefer internal rotation. She's no different. So there I can find balance. And with that anterior motion inferiorly at the fibula, we're typically going to have a posterior motion superiorly. It's not straight posterior. It's like a 45-degree angle, just because of how its structure is relative to the tibia, that their joint is in this plane of motion. So I'm not going to press straight back to find balance. I'm going to press a little bit posterior and medially at the same time, and then also drawing down. So this is like the ankle sprain position. When we sprain our ankles, the fibula gets pulled downward. So to balance it and to balance the interosseous membrane, we also need to remember to check that component, the up and down motion. And there, it's at balance, and it's starting to release. Yeah, just like that. Good. And generally afterwards, I'll just give it a little bit of an articulatory motion at the end, to, encourage it to return to normal motion after the ligamentous imbalance has shifted and is resetting. Okay, this next one for the knee, there are a few ways you can contact the knee. You can go on the surface, the posterior surface, and have the fingers just inferior to the joint line, where the calf tendons are beginning to, or the calf muscles are turning into tendons, and you're just right there where they're becoming tendinous. And then we can manipulate the tibia very easily. I, though, tend to use this one a lot more, where I have both hands on top, so I get a good hold of the femur, a good hold on the tibia. You can alternatively have one hand underneath. This would be especially good if you felt like you needed to engage laxity in the posterior cruciate ligament. And the opposite could be true if you felt like you needed to engage laxity in the anterior cruciate ligament. So thinking about hand position is really helpful because it can give us an advantage in when we go to balance a force that's present already. Like if we want to rotate the spine to the left and someone's supine, well then we should come from the right side, because then the heel of our hand will naturally create that rotation. Okay, but this is my favorite one, is just to have both hands on top. And the first thing I'll always assess is rotation from side to side. And again, this is finding ease, so I'm not struggling, it shouldn't be difficult. It's like feeling for that loose Jenga block. And to find ligamentous balance, we don't need to create a big positional change. We just need to create a change in tension so that the lax ligaments, the tension on them matches or perhaps slightly exceeds the normal ligaments, the ligaments that haven't been strained. So here it's a little bit of external rotation of the tibia with stabilizing the femur. And then so frequently we need compression, but I'll check, compression or traction. And actually in this case, seems like I get a little bit more fluidity with traction. Now there's also this translational motion, so I can translate the femur medially or translate the femur laterally. So what it looks like basically is you can either stabilize the femur and move the tibia. If I push the tibia medially while I stabilize the femur, well that's the same as translating the femur laterally. If I do the opposite, I pull the tibia towards me while stabilizing the femur, well that's the same as translating the femur medially. So in her case, it's a little bit of medial translation of the tibia that helps the most. And there, you get it there, and I can feel that same fluidity, the sense of the tissues preparing to let go, they're softening. And I'm not compressing the fibular head into the tibia. I'm actually not contacting the fibular head at all for this one. I am affecting its position, but I'm not putting force through it. There, and it releases. Then I'll usually, having addressed all of this individually, I will then place one hand just above the knee and the other one back on the calcaneus. So again, here I have a very light engagement. I'm not trying to force or make anything happen or work really hard to find something. I'm just feeling, where is that position of ease? Where does the body want to settle into? And the thing is, it's easy for it to settle into that position. So there doesn't need to be a lot of strain or difficulty. I can, balance plantar flexion here, and also the same thing with the ankle, rotation through the tib fib. I can bring that specificity in, and I can balance external, internal rotation through the femurs. Again, it's important the patient's completely relaxed, that they're not holding any particular position. The most common preference at the femur tends to be external rotation, slight external rotation. So that's more like there doesn't even need to be an injury for that to be present. So when internal rotation is the preference, that's much more suggestive of an injury. So if you don't have an injury that the patient's already told you about, that's a good cue to ask about an injury. There we go, and that releases. All right, two more things that work really well with using the lower extremity. This next one is using the more cephalad hand to place under the pelvis so the fingers extend to the sacrum. They're just over the SI joint on the sacrum, so we can palpate pelvis and sacrum. And it's good to know pelvis position already. She is pretty neutral, but in common compensatory, just a little bit tipped towards anterior rotation on the right. So placing the hand at the upper part of the sacrum, so I can palpate the S1, 2, 3, and so that the palmar surface of my MCP joints are just lateral to the PSIS, the posterior superior iliac spine. I'm already putting that anterior rotation at ease. I'm disengaging that. And 90% of people have that. So when I'm on the left side, frequently if they're posteriorly rotated, my contact is different. I'll actually contact at the ischial tuberosity posterior to it so that it just gently tips the pelvis into posterior rotation and disengages the ligaments. So here I can be aware of all the external rotators, all the internal rotators. I'm not directly contacting the superior inferior gemellus or interior external obturator or the quadratus femoris. I am contacting glute med, glute major, not really the piriformis with this hold, but the summation of all of their tension is what leads to the position of ease. So they, as I'm balancing the ligaments in the femur, in the capsule, and also the anterior ligament that connects the femur there to the acetabulum, then the muscles will also be coming to balance. And again, no stress, just staying relaxed. The body naturally wants to go into the balance. The more we try, the more we effort, the harder it will be. We just need to keep our mind clear and remain available and aware for what the body is already trying to do, available to help it do what it's trying to do. We can disengage the SI joint a little bit by compressing medially. Sometimes that will help. And we can also compress along the length of the femur or traction along the length of the femur. One might think because the pelvis is anteriorly rotated, traction would be the thing. But usually that anterior rotation is involving the iliacus as well. So compression tends to be more helpful, especially when there's this where my hand is behind the upper part of the pelvis so that it keeps it from rotating posteriorly. And there we go. And that releases. I can also place a hand under the lumbar spine and use the femur as a lever to address the lumbar spine. But actually I think that's a little bit out of the scope of treating the lower extremities, because here the effect of our treatment, we're pretty directly working to affect the lumbar spine. I'll still demonstrate it anyways because there's something else I want to talk about, which is how small things in the extremities become big things in the central body. So it's very common for someone to have a history of ankle sprains and to have been dealing with ipsilateral SI joint pain and have done chiropractics, massage, acupuncture, and get temporary relief, but then a return of the SI pain with moderate activity, bending over, gardening sort of work. And frequently what we find is, wow, that imbalance at the SI joint is coming from an imbalance in the ankle ligaments, and it's just being passed up. The ankle is sitting a little funny, so the tib fib sits a little funny, the knee sits a little funny, the pelvis has to tighten up, the muscles around the femur have to tighten up to stabilize, and then it comes out as pain in the SI joint. And that can also then lead to low back pain, and that can create a subtle curve in the spine or a not so subtle curve in the spine that can also be a part of headaches. So everything in the body is connected. And the same way something stuck in the wrist or the elbow can show up, like wrist will frequently show up around the scapula or even going up into the neck. Elbow will frequently show up as diaphragmatic tension on the same side. And you'll see that the lower rib cage is rotating away and side bending towards the restricted elbow. And this is just because the body is a unit. When you get one part of it stuck, like you can see here in cloth, if I pull and twist here, well, it pulls all the way up through here, and that moves. And because nothing is separated in our body, it's all, the fascias all blend into each other, something in the foot can absolutely create a problem all the way up in the head. So this is why it's so important to consider the extremities, to not overlook them, especially in the setting of a problem that is not in a lower extremity, but continually comes back despite being able to relieve it temporarily. Thank you very much for taking the time to watch my presentation. I hope that you enjoyed this and you learned from it, and please check out my other videos, and hopefully you have a great day.